All right, ready to dive deep into some really crucial stuff. Today, it's STEMI management, straight from the 2023 European Society of Cardiology Guidelines.
Yeah, and we're zeroing in on you guys out there on the front lines.
Exactly. Emergency medicine physicians, intensivists, anyone who's dealing with those acute coronary syndromes where,
Every second counts.
we get it. These guidelines, they're massive, so we've really distilled them down to what you absolutely need to know.
Pure STEMI gold. We're not getting sidetracked by unstable angina or NSTEMI, just STEMI.
And you know better than anyone, when it's STEMI, you got to be fast. And you got to know your stuff.
Couldn't agree more. It's all about saving that heart muscle. But before we get into what the ESC recommends, let's make sure we're all on the same page.
Right, what are we even talking about when we say STEMI? What actually defines it?
Yeah, it's more than just your average heart attack. It's a full-on blockage, a complete occlusion of a major coronary artery, a true cardiac emergency.
So we're talking serious damage happening to the heart muscle every minute that ticks by.
And that's why the ESC guidelines really hammer home the need for speed. Diagnose fast, treat fast, minimize that door-to-balloon time.
That window for reperfusion, getting that blood flow back to the heart, that's where we can really make a difference.
Absolutely.
Okay, so the clock is ticking. We've got a confirmed STEMI. What's next?
Well, the guidelines are pretty clear. Primary percutaneous coronary intervention, PPCI, that's the way to go.
I'm sure everyone listening already knows that. PPCI is the preferred way to get reperfusion.
It's consistently shown to be better than fibrinolysis, faster, more complete. But let's be realistic, not every hospital has a cath lab ready to go.
So what happens when a patient shows up at a facility that can't do PPCI right away?
The guidelines do address that. Fibrinolysis is still a valid option, but there are some caveats. It's got to be within 12 hours of when the symptoms started and no contraindications.
The contraindications. That's where things can get a little tricky in the middle of a crisis. The guidelines have a list, but are they all equally important?
That's where your experience, your clinical judgment really comes in. Some contraindications, there's no question, they're absolute.
Like if the patient has had a brain bleed before, intracranial hemorrhage.
Yeah, that's a hard stop. Or active bleeding anywhere internally, except, of course,
Menstruation.
right. But then there are the relative contraindications. Those need more careful thought.
Like a history of ischemic stroke in the past few months. Or even if you suspect an aortic dissection.
It all comes down to weighing the benefits of fibrinolysis against the bleeding risk.
So it's not as simple as just checking off boxes.
No, you got to really think critically, look at the whole patient, and make the call.
Okay, so let's say fibrinolysis, IS, the right choice. The guidelines recommend alteplase or tenecteplase.
Right.
Both work, but I've always found tenecteplase a bit easier to give, just one bolus injection.
Makes things a lot smoother in those high-pressure situations. And remember, for tenecteplase, that weight-based dose, it can't go over 50 milligrams.
Alteplase, on the other hand, it's that whole bolus plus infusion routine. Usually you start with a 50 milligram bolus, then an infusion over 90 minutes.
Which is exactly why having a clear fibrinolysis protocol is so important. You don't want to be scrambling through pages of guidelines when every second counts.
Everyone needs to know exactly what to do, minimize those errors. And even when fibrinolysis works, the guidelines are pretty firm on this next point.
Get that patient to a PCI-capable facility for an angiogram.
Pharmacoinvasive strategy.
Reduces the risk of those ischemic events coming back.
So it's not enough to just get that blood flow back initially. You got to make sure the patient gets comprehensive care to prevent complications down the road. And that brings us to the next phase of STEMI management, the ongoing care.
High-risk patients, the guidelines say they need to be in the CCU or the ICU, continuous monitoring.
Got to be able to catch any complications early on, arrhythmias, heart failure, or even another ischemic event.
And while they're in the CCU or ICU, start them on guideline-directed medical therapy.
Aspirin, P2Y12 inhibitors, beta blockers, statins.
Yep.
It's a multi-pronged approach to give STEMI patients the best chance of recovery. Rapid reperfusion, continuous monitoring, and optimal medical therapy, all working together.
Like a well-oiled machine.
But the machine doesn't just shut off once the patient is stable.
Oh, no, not at all. The guidelines are very clear about the importance of cardiac rehabilitation and long-term follow-up.
To help them recover fully and prevent future problems.
Exactly.
So the journey doesn't end when they leave the hospital. It's about giving them the tools and knowledge they need to live a long, healthy life post-STEMI.
Absolutely. And that's where things really get interesting, moving from that acute phase to managing things long term.
Yeah, it's like a whole new journey for the patient. We've gotten them through the crisis. Now what?
Now we got to map out the road to recovery. And the ESC guidelines, they're like our roadmap. They really stress this holistic approach, not just medication.
Okay, so medication is a big part of post-STEMI care. What exactly does the guideline recommend?
Dual antiplatelet therapy, DAPT, aspirin, plus a P2Y12 inhibitor for at least a year after the STEMI.
To prevent clots, right,
Yeah.
in the stented arteries or where there's still some plaque.
Exactly. Speaking of plaque, the guidelines are also big on aggressive lipid-lowering therapy, high-intensity statins.
Statins, yeah, lowering that LDL cholesterol. But how aggressive are we talking?
We want to get that LDL way down, minimize the risk of plaque rupture and more heart attacks.
So it's not just hitting some target number. It's about getting it as low as you safely can.
Right. And for most STEMI patients, the guidelines also recommend beta blockers and ACE inhibitors.
So it's a multi-pronged approach, each medication doing its part.
Beta blockers ease the workload on the heart, help it heal. ACE inhibitors protect against remodeling and further damage.
It's like giving the heart extra support, helping it bounce back stronger. But medication isn't the whole story, is it?
No way. Lifestyle changes are just as important. We need to help our patients make those changes that'll really make a difference.
So the usual stuff: stop smoking, healthy diet, exercise, manage stress. But how do we actually get patients to do that?
That's where communication and education come in. You gotta explain why these changes matter, tie them to the patient's own experiences and goals.
So it's not just handing them a pamphlet, it's having that personalized conversation.
Exactly. And remember, those lifestyle changes, they not only reduce the risk of heart problems, they improve overall health and well-being.
It's about shifting the focus from just the disease to the whole patient, empowering them to take charge of their health. Speaking of empowerment, what about cardiac rehab?
Cardiac rehab. So important, but so often overlooked. The guidelines are strong on this. All STEMI patients should be in a structured program.
So it's not just resting at home. There's more to it.
Yeah, cardiac rehab is supervised. It combines exercise, education, and counseling.
Like boot camp for the heart.
Kind of, but with a holistic approach. Exercise gets the heart stronger, education helps patients understand their condition, and counseling provides support.
It's dealing with both the physical and the emotional impact of a heart attack.
Right, because a STEMI can be traumatic. And the research shows cardiac rehab really helps. Reduces future events, improves quality of life.
So it's not just an option. It's essential for long-term STEMI management.
It's an investment in their health, both body and mind.
Now, medication, lifestyle, cardiac rehab, those are the basics. But there are some situations that need a more tailored approach, like multivessel disease. What about those patients?
Multivessel disease, that does add another layer of complexity. But the ESC guidelines do have recommendations for those cases.
So how do you approach revascularization in those patients? Do you try to fix everything all at once?
No, the guidelines recommend a more staged approach. First, open up that culprit artery, the one causing the STEMI, as fast as possible.
So stabilize the patient, deal with the immediate threat, then reassess.
Right. Then, depending on how stable the patient is and how complex the other lesions are, you can consider complete revascularization, either during the same hospital stay or as a planned procedure later.
So it's about weighing the risks and benefits at each step. But how do you decide whether to do complete revascularization or leave the other blockages alone?
That's where you use angiography and functional assessments like FFR, fractional flow reserve.
FFR, so you can see if those other blockages are actually restricting blood flow. It's not just how narrow the artery looks on the angiogram.
Exactly. FFR lets you personalize the strategy based on the patient's specific anatomy and physiology.
So moving away from a one-size-fits-all approach to a more tailored strategy. Now, multivessel disease is a clear anatomical challenge, but there's another type of heart attack that's kind of a mystery: MINOCA, myocardial infarction with non-obstructive coronary arteries.
MINOCA. The heart attack with no obvious cause. You see all the signs of a heart attack, troponins elevated, but the angiogram doesn't show any major blockages.
So a heart attack without the blocked artery, what's causing the damage then?
That's the big question. The ESC guidelines really emphasize a thorough workup to figure out the underlying cause of MINOCA, and there are a lot of possibilities.
So you have to think outside the box. Coronary spasm, microvascular dysfunction, spontaneous coronary artery dissection, SCAD, even things that aren't heart-related, like myocarditis.
It's like detective work, piecing together the clues. You might need a cardiac MRI, an echo, even genetic testing sometimes.
So managing myocarditis is a bit more complex. You can't just rely on the angiogram.
Right. And once you have a diagnosis, then you can tailor the treatment. Like if you suspect SCAD, you might go with a more conservative approach, focusing on medical therapy instead of interventions.
So another example of personalized medicine. Not jumping to conclusions based on the angiogram alone, but looking at the whole picture.
And it's important to remember, even though the angiogram might not look as dramatic, myocarditis is still a heart attack. These patients need proper management to prevent future problems.
Okay, so we've covered multivessel disease, the complexities of myocarditis, and the importance of long-term management. What else should clinicians keep in mind when they're taking care of STEMI patients?
The guidelines really highlight the importance of a multidisciplinary approach. It's not just the cardiologist, it's the interventionalist, the cardiac surgeon, the nurses, the pharmacists, even physical therapists and dietitians.
A whole team effort.
Absolutely. Everyone working together, communicating effectively, that's how you get the best outcomes for the patient.
And with all the technical stuff, we can't forget about the patient's perspective. The guidelines talk about shared decision-making and patient-centered care.
Involving patients in the decisions about their treatment, explaining the risks and benefits, respecting their preferences.
Empowering them to be active participants in their care. Now, these guidelines are comprehensive, but they can't cover every single situation. What should clinicians do when they have a complex STEMI case that isn't directly addressed in the guidelines?
That's where clinical judgment comes in, the experience you've built up over the years. The guidelines provide a framework, but you always have to consider the individual patient, their presentation, their medical history, their preferences.
So using your knowledge and experience to make the best decision for that specific patient, even when the guidelines don't have a clear-cut answer.
And remember, medicine is always changing. New research is coming out all the time. We have to stay up to date.
That's what makes being a clinician so interesting. You're always learning, always looking for ways to improve.
It's a journey of continuous learning, and the ESC guidelines are a great guide along the way.
Well said. Before we wrap up this part, I want to go back to something we talked about earlier. Time.
Time is muscle when it comes to STEMI. Every minute without reperfusion means more risk of permanent damage and complications.
We've talked about the importance of diagnosing and treating quickly, but it's worth repeating. It's a message we have to keep reinforcing, both with healthcare professionals and the public.
Absolutely. People need to know the symptoms of STEMI. They need to know to get help right away.
Because with STEMI, every second counts. We're going to take a break here, but stay tuned for the final part of our deep dive. We'll cover some more considerations for STEMI management and leave you with some final thoughts.
Welcome back. Glad you stuck with us. We've been exploring all the ins and outs of STEMI management, from those crucial first interventions to the long haul of recovery.
We've covered a lot, but for this last part, I kind of want to shift focus a little. Let's talk about the patient experience.
Yeah, that's so important. It's easy to get caught up in all the protocols and forget about the person in the middle of it all.
Exactly. So how can we, as healthcare providers, do better? Not just taking care of their physical needs, but supporting them emotionally too.
Well, the ESC guidelines do touch on that. They talk about communication, empathy. You know, for most patients, a STEMI, it's a life-changing event.
They're scared, confused, probably wondering what their life's going to look like now.
Right. So you got to take the time to answer their questions, really address their concerns, involve them in the decisions when you can.
Give them back some control, some sense of agency in all of this. I think that can make a big difference.
Absolutely. And sometimes it's the little things, a reassuring touch, just listening to them, a kind word.
It all adds up,
Right.
reminding them that we see them, not just their heart condition.
It's about caring for the whole person.
So beyond the hospital, what about the long-term stuff? What can we do to help them navigate what comes next?
We already talked about cardiac rehab, how important that is. But even beyond that, there's a lot we can do.
Like?
Education is huge. Empowering patients to really understand their condition, what their risk factors are, how they can change their lifestyle, and explaining the why behind it all.
So not just telling them what to do, but helping them understand the reasoning behind it.
Exactly. And change is hard. Don't be afraid to bring in the rest of the team. Dietitians, exercise physiologists, psychologists, support them every step of the way.
It's like building this network of support that extends way beyond the hospital.
That's the goal. And don't forget about follow-up appointments. Checking in regularly lets us see how they're doing, adjust meds if we need to, address any new issues.
It's about that ongoing relationship between provider and patient, working together to keep them healthy in the long run.
That's what it's all about. And as we wrap up, I want to leave you with this thought. Managing STEMI, it's not just about following the rules. It's about taking those guidelines and combining them with compassion, empathy, really understanding what the patient is going through.
It's about remembering that behind all the data, the ECGs, the angiograms, the lab results, there's a person whose life has been totally turned upside down by this.
And it's our job to help them through that with everything we've got, our skills, our knowledge, and our hearts.
Couldn't have said it better myself. Well, that brings us to the end of our deep dive into the 2023 ESC guidelines on STEMI management. We hope you found it helpful, that you walked away with some practical things you can take back to your practice.
Remember, knowledge is powerful, but it's putting that knowledge into action with compassion and empathy that really makes a difference for our patients.
To everyone out there working on the front lines, thanks for all you do, for being there in those moments when every second counts. Keep learning, keep asking questions, and keep pushing the boundaries of care.
Until next time, stay curious, stay informed.